B of chapter 18. And again, I apologize for my voice. I lost it. I got a cold. Um, so I'm just trying to get through this. So thanks for listening. So we talked about the anatomy of blood vessels. And now this part B, we'll talk a little bit of physiology. The blood flow is just the volume of blood flowing through a vessel, organ, or entire circulation in a given period. It's measured in milliliters per minute. It's equivalent to cardiac output for the entire vascular system. Overall, it's constant at rest, but at any it can based on blood pressure is the force per unit area exerted blood vessel by millimeter of mercury, and it's measured as systemic arterial blood pressure in arteries near the heart. Pressure gradient will provide a force that keeps the blood moving from a higher to lower pressure area. Resistance, also known as peripheral resistance, is the opposition to flow, and it's measured by the friction blood encounters within the blood vessel walls. There's important sources of resistance: the blood viscosity, total blood vessel length, and blood diameter. Viscosity refers to the thickness or stickiness of blood. It refers to that the longer the vessel, the greater the resistance will be. And then blood vessel diameter is the greatest influence on resistance. There's frequent changes that will alter the peripheral resistance, and the fluid close to the walls will move more slowly than in the middle of the tube, and this is called laminar flow. Power of the vessel radius for will materials are the major determinants of peripheral resistance. Their radius changes frequently in contrast to larger arteries that do not change as often, and abrupt changes in vessel diameter or any sort of obstacle like a fatty plaque from atherosclerosis. Turbulent flow, which is an irregular flow that causes increased resistance. So an example we show is drinking out a milkshake. Whether you drink from a narrow straw with a narrow lumen or a more dilated, larger, actually give you more milkshake to drink. Blood flow is directly proportional to the blood pressure gradient. Resistance. So resistance increases, the blood flow pressure decreases. And you don't have to memorize these formulas at all. Systemic blood pressure then is the pumping action of the heart that will generate this blood flow. It's the pressure that results when the flow is opposed by resistance from the heart and will decline throughout the pathway. And the steepest drop off will occur in mercury will be highest in the aorta, off, especially in the arterioles, will have the largest drop off. And then the pressure is much lower in the veins and in the vena cava as well. The arterial blood pressure is determined by elasticity, which is the stretching or distensibility of arteries close to the heart and the volume of blood forced into them at any time. Blood pressure in the heart is pulsatile, so it will rise and fall. Systolic pressure refers to the pressure exerted in pressure when the heart is at rest. Pulse pressure is the difference between is the throbbing of arteries to different pressures, which the mean arterial pressure is the pressure that propels blood to the tissues. The heart spends more time in diastole, so it's not just a simple average of the two. This is how we calculate mean arterial pressure. Um, it's calculated by adding diastolic pressure plus a third of the pulse pressure. So if blood pressure is 120 over 80, if your blood pressure is 120 over 80, is 80 plus 1/3 of the pulse pressure, which is 40. So that is equal to about 93 millimeters of mercury to get your mean arterial pressure. The pulse pressure and the mean arterial pressure both decline with increasing distance from the heart. I do want you to know how to calculate the mean arterial pressure. Again, you add the diastolic pressure plus 1/3 of the pulse pressure. Clinical monitoring of circulatory efficiency. Vital signs are the pulse and the blood pressure, which are often taken in a clinical setting, along with respiratory rate and body temperature. So, to take a pulse, you can take the radial pulse taken at the wrist, and pressure points are areas where arteries are close to the body surface. They can be compressed to stop blood flow in an event of a hemorrhaging. So, these are body sites where the pulse is most easily palpated. We probably feel on the radial artery in our wrist or in the common carotid artery the best. You can also feel it in your forehead, the facial artery, the groin, the brachial artery, the popliteal, and also on the foot or the ankle with those arteries. In order to measure blood pressure, systemic arterial blood pressure is measured indirectly by oscillatory where you wrap the cuff around systolic pressure in the brachial artery, and then pressure will be released slowly, and the examiner will listen for the sounds of carot cough with a stethoscope. This the turd, which will be starts to spurt through the artery, and diastolic pressure is normally less than 80, and this will be the pressure when sounds disappear because the artery is no longer constricted and blood flows freely. Your capillary blood pressure ranges from 35 at the beginning of the capillary to about 17 at the end of the bed. Low capillary pressure is very desirable because a high blood pressure would rupture the fragile thin-walled capillaries, and most capillaries are very permeable to infiltrate. Venous pressure then changes a little during the cardiac cycle. There's a small pressure gradient. Low pressure of the venous side requires adaptations of the turn, but for the most part, your veins have blood pressure in them. Factors that aid this return back to the heart is the muscular pump, which is the contraction of skeletal muscles, which will milk or squeeze the blood back toward the heart. Valves will help prevent backflow. The respiratory pump, pressure changes during breathing, will also move blood towards the heart by squeezing your abdominal veins as the thoracic veins expand. And sympathetic vasoconstriction, this will be under sympathetic control. Smooth muscles will constrict, which will also push blood back toward the heart. So this is a look at the muscular pump contracting, kind of squeezing or pushing the blood up the veins, and the valve opening and closing to try to keep the blood at a height above. Um, also help blood flow back to the heart. Um, there's three main factors that regulate blood pressure: the cardiac output, peripheral resistance, and the blood volume. And blood pressure will vary directly with cardiac output, peripheral resistance, and blood volume. This is a look at regulating blood pressure. Um, you don't have to know these equations. Just understand that blood pressure, the mean arterial pressure, will be directly proportional to both cardiac output and peripheral resistance. So what that means is if you change one of these variables, um, the other will be quickly compensated for by changing others. So that anything that increases stroke volume, heart rate, or peripheral resistance will also increase the mean arterial pressure. Factors can be affected by short-term regulation from the neural controls, nervous system, short-term regulation by your hormones, or long-term regulation by your kidneys, your renal controls. So these are major factors that increase in stroke volume, increase in heart rate will increase your cardiac output. If the diameter of your blood vessels decreases or blood gets stickier or flow increases, that'll increase total peripheral resistance. So both will increase the mean arterial pressure. Two main neural mechanisms control peripheral resistance. It is maintained by altering the blood vessel diameter, and it can alter the blood distribution to organs in response to specific demands. So your neurons will control operating reflex arcs that involve the cardiovascular center of the medulla, baroreceptors, chemoreceptors, and higher brain centers. The cardiovascular center is composed of clusters of sympathetic neurons. They have cardiac centers and vasomotor centers. They both will receive input from different baroreceptors, chemoreceptors, and higher brain centers to initiate some sort of response. Your baroreceptors are located in the carotid sinuses, your aortic arch. If mean arterial pressure is too high, increased blood pressure will stimulate these baroreceptors to increase input to the vasomotor center. This will inhibit vasomotor and cardioacceleratory centers, stimulating a cardioinhibition center, decrease blood pressure. The baroreceptor reflex will result in decrease in blood pressure due to two mechanisms: through vasodilation, which is decreased output from your vasomotor center causing dilation, and also decreased cardiac output. Impulses to the cardiac centers will inhibit sympathetic activity, stimulate parasympathetic activity, which will reduce the heart rate and contractility of the heart. So this takes time to mean arterial baroreceptor reflexes will respond. So you can pause this lecture and read through the following. And this takes you through visual representation of what will happen if we get any sort of homeostatic imbalance of it being too high or too low, and how the brain will respond to that. The chemoreceptor reflex found in the aortic arch and large arteries of the neck that detect increases in drop in pH or oxygen. It causes an increase in blood pressure by signaling the cardioaccelerator monoxide or carbon dioxide motor center to increase vasoconstriction. Of higher brains, reflexes that regulate blood pressure are found in the medulla. Your hypothalamus and cerebral cortex can modify arterial blood pressure via relays to the medulla, and the hypothalamus increases blood pressure during stress, and your hypothalamus will also mediate the distribution of blood flow during exercise and changes in body temperature. Here are some different hormones that regulate blood pressure. From the adrenal medulla, we have epinephrine and norepinephrine, which increase vasoconstriction. Angiotensin 2 will stimulate vasoconstriction, and ADH, high levels, can cause vasoconstriction. And the AMP, atrial natriuretic peptide, will decrease blood pressure, and that is from the heart. So these are the different hormones and the effects of selected hormones on the blood pressure. Long-term mechanisms include renal control. Long-term mechanisms will control the blood pressure by altering the blood volume via the kidneys, and the kidneys can regulate arterial blood pressure by direct renal mechanism or indirect renal mechanism. Direct involves altering blood volume independently of hormones, so increasing blood pressure or blood volume causes elimination of urine, thus reducing blood pressure, and decreased blood pressure or blood volume causes your kidneys to conserve or retain water, and that causes your blood pressure to rise. And this is a look at a direct and an indirect renal mechanism, going through the renin-angiotensin-aldosterone system, which we talked a little bit about in your endocrine part. The direct renal mechanism, either secreting more urine formation or retaining water. The long-term mechanisms, the indirect mechanism includes this renin-angiotensin-aldosterone, where if you have a decrease in blood pressure, it causes release of renin, which will convert angiotensin to angiotensin 1. An angiotensin converting enzyme from the liver converts this angiotensin 1 to angiotensin 2. And angiotensin 2 is what acts in 4 different ways to stabilize your arterial blood pressure: stimulating aldosterone secretion, which causes ADH release. This acts as a potent vasoconstrictor, increasing blood pressure, and also your thirst center to drink more water. The goal of blood pressure regulation is to keep your blood pressure high enough to provide adequate tissue perfusion, but not so high that blood and the person will lose consciousness. And if blood pressure to the brain is too high, the person could have a stroke. So these are all factors that heart in the diameter of the blood vessels. Regulation of blood pressure, then, some homeostatic imbalances. Transient elevations in blood pressure will occur during different changes in posture, physical exertion, emotional upset, or fever. Your age, your sex, your weight, your race, and your pressure to vary. Hypertension is sustained elevated arterial pressure of 140 or above 90 or higher. Pre-hypertension are these values are elevated but not yet in the hypertension range. Prolonged hypertension is a major cause of heart failure, vascular disease, renal failure, and stroke. The heart must work harder and the myocardium will enlarge, especially the left ventricle. It'll cause the heart to weaken and become flat, and it can also accelerate. Primary hypertension is about 90% of hypertensive conditions. There's no underlying cause, but some risk factors could be stress, smoking, diabetes, diet, obesity, anything hereditary. There's no cure, but it can be controlled with restricting salt and fat and cholesterol intake, increasing exercise, losing weight, stopping smoking, or secondary hypertension is common due to an unidentifiable disorder like obstructive renal arteries or kidney disease, and the treatment would focus on correcting the underlying cause. Hypotension then is low blood pressure. It's usually not unless it life and lack of cardiovascular illness. Orthostatic hypotension is temporary low blood pressure and dizziness when suddenly rising from a sitting or reclining position. Chronic hypotension can be a hint of poor nutrition and a warning signs for Addison's disease or hypothyroidism. And acute hypotension is an important sign of circulatory shock. This circulatory shock, that is a condition where blood vessels are inadequately filled and cannot circulate your blood normally. Hypovolemic shock results from large-scale blood loss. Vascular shock results from extreme vasodilation and decreased peripheral resistance. And the cardiogenic shock results when an inefficient heart cannot sustain adequate circulation. And that's the end of this chapter for part B. Thanks for listening, guys.